Hi, everybody. Welcome back. I hope you had a nice lunch. I was a little dismayed that only one person put their lunch plans in the chat. Kyle says spicy chicken Caesar salad. Mine was excellent. Still kind of chewing, as a matter of fact. Sorry about that. We're on to session 4, Shared Vision, a nursing researcher's exploration of healthcare accessibility with a blind partner. And this will be moderated by Maya Beheshti, uh, who will introduce our speaker. Take it away.
Thank you, Dr. Pose. Hi, everyone. It's so great to be here with you. A quick visual description. I'm a medium-toned woman with shoulder-length dark hair, wearing black glasses, a white shirt, and a navy blazer with a blurred background behind me. I'm a physician scientist at Rusk Rehabilitation and NYU School of Medicine, where my work focuses on neurorehabilitation and development of assistive technology. I'm also bringing medicine and engineering together as a part-time PhD candidate in mechanical and aerospace engineering at NYU Tandon School of Engineering. Today, it's truly my pleasure to introduce our speaker, Dr. Suyang Chu. Dr. Chu is an assistant professor in Department of Health and Kinesiology at University of Illinois, Urbana-Champaign. She leads the Accessible Healthcare Lab, driving innovation in the mobile health technologies and health information system for people with visual impairments. As a registered nurse and also certified accessibility expert, she combines clinical expertise with research and education to advance disability-inclusive healthcare. Let's give a warm welcome to Dr. Cho. Dr. Cho, the floor is yours.
Thank you for the kind introduction. I will share my screen first. Good morning or good afternoon. It's truly a privilege to be here with all of you today. My visual description is that I'm a woman in my 30s, originally from South Korea. I identify as Asian, and today I'm wearing a white button-down shirt, black hair, and wears pearl earrings and necklace. That's my visual presentation for today. And the title of my presentation is Shared Vision, a nursing researcher's exploration of healthcare accessibility with a blind partner. As the title suggests, I will be sharing insights drawn from my lived experience navigating the US healthcare system alongside my blind partner. Based on this journey, I will discuss the critical efforts needed to improve healthcare accessibility for blind and low vision patients. As you heard in the first brief introduction, let me briefly share a little bit of background. I'm trained in nursing and worked for 3 years as an intensive care unit nurse at a university hospital in South Korea. And during my master's studies, I also had the opportunity to supervise clinical practicums for undergraduate nursing students. Later, I came to the United States to pursue my doctoral research at Pennsylvania State University. And during that time, I met my husband, who is totally blind, at a Korean church. After we got married, we both began our academic careers as assistant professors at the University of Illinois. Most of the research questions I place on the table stem directly from the everyday accessibility challenges that my husband and I encounter together. This can be understood as a form of a dual ethnographic approach, where both of us contribute lived perspectives. His as a blind individual, and mine as a healthcare researcher and caregiver. Geoethnography is a research method in qualitative study. This is a collaborative ethnographic method involving two people, often from different positionalities, jointly reflecting on their lived experiences. Guided by this methodological approach, my research aims to address real world problems experienced by blind persons with the goal of generating practical, meaningful solutions that can truly enhance their health related quality of life. Let me share two representative examples from our personal experiences with the healthcare system that highlights some of the critical accessibility challenges we encountered. My husband was born with congenital glaucoma, and over time, he progressively lost his vision. Recently, he developed cataracts in addition to glaucoma, which required laser therapy. This marked the first time I accompanied with him and to an eye exam in the US after our marriage. With a background in nursing and clinical experience, I'm quite familiar with hospital environments. Naturally, using the US healthcare system has led me to comparing with the system in South Korea. While my observations are based on experiences at a single hospital and may not be fully generalizable, there were several moments that left a strong impression on me. First, at nearly every visit, new nurses and doctors asked my husband the same repetitive questions. Which eye is prosthetic? Which one retains some vision? And how much vision he has left. In fact, one provider even attempted to examine his prosthetic eye. In South Korea, electronic medical record (EMR) systems typically display key patient information such as type of disabilities and significant medical history and allergy information right next to the patient's name. So I found it puzzling that here the same questions were being asked repeatedly. Reviewing a patient's charts and familiarizing oneself with essential patient background information should be the most basic form of preparation before entering the exam room as a healthcare provider. Another point I found troubling was that healthcare providers often spoke to me, the accompanying spouse, instead of directly addressing my husband. Even more concerning, they rarely provided detailed descriptions of the eye's conditions, including imaging results. I recall one visit when I described the image findings to my husband myself, saying something like this: "Honey, your microvessels in your eye appears reduced and narrows, and there seems to be a jelly-like liquid forming." My husband was amazed to hear this. The visualized described information that should have been shared with him by the medical team, not from me. I, on the other hand, was also surprised that no one had thought to explain it to him directly. The second experience I'd like to share is from a very personal and recent part of our lives. I'm currently 36 weeks pregnant, and throughout this pregnancy, my husband has accompanied me to every fetal ultrasound appointment. For many expectant parents, seeing the tiny embryo gradually develop into the shape of baby is not only deeply moving, it's often the very beginning of forming a bond with the unborn child. It's a moment filled with awe, connection, and a growing sense of life's dignity. However, for my husband, each visit to the ultrasound room has meant quietly sitting in the corner, listening only to the machine's beeping sound and clicking sound, or sometimes the baby's heartbeat. He was never included in the visual experience, which plays such a central role in connecting with the fetus during this early month. I found myself thinking how difficult it must be for him not to be able to see this first glimpse of our child. So I asked him one day, would it be helpful for you if I capture the ultrasound image from my chart application, converted it using swell form printing so you could touch and feel the shape of our fat baby? He appreciated with this idea, and during our next visit, he politely asked about to the nurse if it would be possible to receive the image file in a PDF format by email. The nurse seemed unsure and told him she would check, but we never heard back. Eventually, he gave up on the request. I asked him why he didn't follow up. His response struck me very deeply. As a blind person, I've learned over time that when I make requests, even simple ones, they're often seen as burdensome. I end up being perceived as the person who complicates things. So eventually I stop asking. I learn to accept the things as they are. His words reflect not just an individual experience, but a broader reality that many blind and low vision patients are quietly discouraged from advocating their needs, not because they lack agency, but because the system signals in subtle or not so subtle ways that their needs are too much. While we have numerous legal frameworks in place to protect the rights of patients with disabilities within the healthcare system, but the reality is that these laws are often not meaningfully upheld in practice. We know the existence of Americans with Disability Acts, and we know Rehabilitation Act of 1973. In theory, the rights are there, but in practice, the system continues to fail many of the patients it claims to serve. The most common issue of health information accessibility for blind and low vision patients is deeply concerning because they cannot read printed materials. They must rely on someone else, specifically sighted people, often a family member or friend, to read sensitive medical documents aloud. Without alternatives such as Braille, large print, or accessible digital formats, printed information is just paper to them, devoid of meaning, autonomy, and privacy. Healthcare professionals must recognize just how critically important accessibility is, not only for patients with disabilities, but also for their families and caregivers. Overall, United States policies strongly support accessibility information in the context of healthcare, but still, many patients with blindness experience have uneven experiences. Some blind patients receive exemplary accommodations, luckily, while others still struggle with basic communication barriers. So, improving accessibility is not just a legal obligation, it's a kind of human responsibilities. And Every time my husband needs to schedule a medical appointment, the first thing he does is check my Outlook calendar. If I'm unavailable, he simply can't go. That's because I serve as his appointment companion, driver, and communication bridge, roles that extend far beyond those of a typical spouse. In reality, his autonomy and independence in accessing healthcare services are often invisible or, at best, heavily mediated through me. And while I willingly and lovingly support him, I must admit that there are moments, especially as a family member, when it feels overwhelming. There are times when the burden of navigating an inaccessible healthcare system weighs heavily on me too. This isn't just about logistics. It's about how much we still rely on informal support systems like family caregivers to compensate for what the healthcare system lacks in accessibility. I first encountered the concept of accessibility through my husband's research in human computer interaction. My husband, who is totally blind, has always had a passion for math and science since childhood. Actually, he did well. However, because the special education schools in South Korea did not offer STEM subjects for blind children, so he was denied the opportunity to formally study the subject he loved. In response, he has taken upon himself to develop software that uses artificial intelligence to make STEM education accessible to blind students, including tools that render mathematical content in Braille and generate tactile graphs or audible graphs for hands-on learning. Given the intersection between our research fields, his in accessible computing and mine in healthcare accessibility, we often collaborate on interdisciplinary projects. Our shared goal is to ensure that accessibility is not just a technical feature, but a foundation for equity across education, health, and daily life. Before I introduce a few of my research projects, I'd like to take a moment to provide some background, especially for those who may not be familiar with how blind and low vision persons interact with digital technologies such as computers and smartphones. The most widely used assistive technology for blind and low vision persons is the screen reader. A screen reader is a software program that converts the content displayed on a digital screen into speech. It reads aloud everything on the screen, typically from top to bottom and left to right, allowing users to navigate through text, menus, buttons, and other interface elements using keyboard commands or touch gestures. So screen readers are essential tools for enabling independent access to information on computer, smartphone, tablet, and any other digital devices. Another key approach to improving information accessibility for blind and low vision individuals is through tactile-based technologies. These tools leverage the sense of touch to convey information. The most familiar examples include Braille, a system of raised dots that represent letters and numbers, and tactile graphics such as embossed diagrams, raised line charts, or 3D maps. These tactile formats allow users to access spatial, numerical, or visual information in a hands-on, non-visual way, making them especially valuable in contexts like education, navigation, and health communication. I believe that tactile technologies hold particular promise when it comes to medical image accessibility for blind and low vision patients and their family caregivers. For instance, the pattern of tumor on a scan or the structure of a bone break on an X-ray could be felt through a force feedback pen or vibrating touchpad or swell foam printed materials. One of the most innovative technologies supporting tactile access to digital information will be the refreshable braille display. Refreshable means it updates in real time. As the user navigates, the braille changes, just like scrolling on a screen. We can employ this technology for blind patients in healthcare settings. We can empower blind patients to read medical records, prescriptions, and educational materials independently. Definitely, we can adopt this technology for making them to access their medical imaging results. To share one example from my research project, I applied this tactile technology in a study involving a mobile health application we developed to promote physical activity levels among blind and low vision persons. When participants first downloaded and began using the mobile health application, we provided them with tactile representations of the application's user interface, converted into raised line diagrams using swell form printing. These allowed users to feel the layout of the screen, including the placement of buttons, navigation tabs, and icons. This device we call the swell form printer. It creates tactile graphics on special swell paper. It uses heat to raise black inked areas, forming raised lines and textures you can feel. So it works with microcapsule paper or the other terms will be swell paper. This is a assistive technology to make blind people to use their touch sensory to access visualized information. This slide includes some figures explaining the process of producing a tactile mobile health application user manual. First of all, my research assistant developed a very first draft using Word software program. And then using Adobe Illustrator, we developed the overall outlines. And then we add some Braille information and we organize some buttons, locations, and we try to introduce the layout designs of our developed mobile health application. So by looking into this tactile manual, blind users can understand the layouts of the mobile health application that they're gonna use. So they can be more familiar with the initial use of the mobile health application. And the third promising technology for improving information accessibility among blind and low vision individuals is artificial intelligence, AI, particularly through the use of multimodal AI models like ChatGPT, Gemini. These models have the remarkable ability to process and generate information across multiple formats, including text, images, and speech. For blind users, this means that AI can serve as a powerful conversational assistant capable of describing visual content, summarizing complex documents, or answering health related questions, all through voice interaction. In one of my recent research projects, I applied this large language model, the OpenAI's GPT-4o, to support health data monitoring. In another word, personal health tracking for blind and low vision individuals. Specifically, we explored how conversational AI could help users interpret and interact with their personal health data, such as physical activity levels, heart rate, or medication reminders. I have also published a theoretical paper exploring how the rapid growth of mobile health technologies is reshaping traditional self-care models. Historically, self-care theories have emphasized patients' ability to monitor, manage, and respond to symptoms using their own knowledge and judgment. However, um, with the emergence of real-time, sensor-driven, and AI-supported health technologies, self-care is becoming increasingly digital, dynamic, and data-informed. However, most mainstream mobile health tools available to the general public are highly visual in nature, relying on charts, graphs, color-coded indicators, images, photos, and touchscreen interfaces. As a result, blind and low vision individuals often face significant challenges when trying to use these applications. Important features like tracking symptoms, viewing trends, or receiving health alerts are often inaccessible without visual cues or proper screen reader compatibility. So there are multiple barriers in mobile healthcare systems. To address these challenges, my research team integrated a large language model, OpenAI's ChatGPT 4o, into our mobile health application to enable conversational access for blind and low vision users. Instead of relying on visual navigation, users can simply talk to the app, asking questions about their health data, or issuing commands to operate app's main features. For example, blind users might say, "Tell me how many minutes of exercise I logged this week," or "Remind me to take my medication at 8 p.m." or "Wake me up at every 8 a.m. in the morning for my exercise," like this. This slide includes some representative user interfaces of our application and system architecture. So we connect Apple Watches to the data collection server, and we also connect them to our developed mobile health application. And we also provide ChatGPT 4o to enable conversational agent functioning. This conversational interface transformed the user experience from a visual, menu-driven process into a natural, dialogue-based interaction, making the app not only more accessible, but also more intuitive and empowering for blind users. The third research example that we conducted, I want to share, involves the use of narrated exercise videos with audio descriptions designed specifically for blind and low vision individuals. In this project, we focused on making physical activity content more accessible by adding descriptive audio narration that explains each movement, posture, and transition in real time, rather than relying on visual cues alone, as is common in most mainstream fitness videos on YouTube. We ensured that blind users could fully understand and follow the workout using only sound or audible instructions. The final accessibility related research project I like to share involves the development of a curriculum designed to teach applied health sciences students why the concept of accessibility is essential in healthcare systems. Previous research emphasized training clinicians to implement holistic practices for patients with disabilities and notes that seemingly small actions can improve care experiences among blind patients, as well as any other types of disabilities. So this project was funded by Teach Access, which is a nonprofit collaboration institute. It provides a partnership of tech companies, universities, and disability advocates. Its mission is to embed accessibility and inclusive design into higher education curriculum. So, by using this research fund, I decided to propose a new accessible healthcare curriculum for future healthcare leaders. Through this project, I created educational modules that help future healthcare professionals understand how barriers to access impact patient care, especially for individuals with disabilities. The curriculum introduced foundational concepts such as the social model of disability, universal design, and equity in health communication, while also incorporating real world case studies and reflective activities. The goal is to give students not just with clinical knowledge, but with the awareness and empathy needed to design and deliver accessible, inclusive healthcare from the very beginning of their careers. This slide includes some group project output. So students present their final team project. So to share their discussion over accessibility challenges in healthcare settings for people with disabilities. Students who participated in this curriculum evaluation shared very positive feedback. Many expressed that they were able to gain a clear understanding of what accessibility truly means within a healthcare context beyond just physical accommodations. So far, I've shared several of my research projects aimed at improving healthcare accessibility for blind and low vision individuals. Drawing from these experiences, I'd like to conclude by offering a few practical recommendations for healthcare professionals, those of you who are in the best position to create real, meaningful change on the ground. Healthcare professionals must be equipped not only with clinical knowledge, but also with a deep understanding of disability rights, patient autonomy, and person centered care. When we educate ourselves about the lived experiences of people with disabilities, We build the empathy required to care for them more effectively and equitably. The second point is simple but powerful. Ask, don't assume. Too often, healthcare providers unintentionally bypass blind or low vision patients, addressing their caregiver or making assumptions about what they can or cannot do. But every patient deserves to be spoken to directly. This small shift in communication can dramatically increase a patient's sense of autonomy and respect. And inclusive language matters. Words shape relationships. Something as simple as asking, how would you prefer to receive this information? This shows you that you recognize and respect individual differences in access needs. It invites the patient into the conversation as an active partner in their care. So in the end, we can improve their satisfaction levels of the provided healthcare services. And accessibility should not be a reactive add-on or something that only comes into play when a patient requests it. Instead, it needs to be built into every step of the care journey. When accessibility is part of the default workflow, it benefits not only patients with disabilities, but all patients, creating smoother, more consistent care experiences. Next, we must standardize accessibility checks. Just as clinicians routinely check for allergies or medication history prescriptions, staff should be trained to ask patients how they prefer to receive health information and what kind of approaches they prefer during their medical consultations. This simple habit can prevent serious communication gaps and shows that we respect each patient's communication needs as a standard part of care, not an exception. As I introduced you before, there exists lots of technologies for improving the standardized accessibility checks. By using innovative technologies, definitely we can improve the accessibility of medical information for patients with disabilities and offer accessible defaults. Don't wait for a patient to request alternatives. Proactively make accessible formats available. When these options are visible and offered as standard, it reduces the burden on patients as well as their family caregivers to advocate for themselves and signals that accessibility is a fundamental part of healthcare quality. And I humbly propose to provide mandatory accessibility training for both clinical and administrative staff. Making this training mandatory sends a powerful message. Accessibility is not optional, it's essential. Then we must create patient-centered feedback loops. Healthcare systems often talk about patient-centered care, but rarely do we systematically listen to blind and low vision patients about what's working and what it isn't. By regularly collecting insights from blind and low vision patients, we can identify overlooked barriers, prioritize improvements, and continuously evolve our services to better meet their needs. This can apply for all types of disabilities. Finally, we need to co-design with blind and low vision patients, not just for them. These ideas should be developed from the direct end users. Whether it's developing a mobile health applications, redesigning clinical signage, or physical environments, or revising communication protocols, Blind and low vision persons bring critical expertise drawn from their lived experience. Inviting them into the design and decision making process ensures that the solutions we create are not only technically sound, but genuinely usable, inclusive, and respectful. So that's the reason why I really like the co-design approach for my mobile health technology development work. In my research lab, my research team typically initiate the development project by collaborating with blind research participants. We invite three or four, five blind research participants to our research meetings, and we try to hear their voices first. And after the initial prototyping, we want to gain their opinions through their user tests. This approach makes more research outputs feasible for real-world cases. Today, I have the privilege of speaking to all of you, many of whom have far more extensive clinical experience with patients than I do. What I shared came from a different perspective, my lived experience as a partner to a blind individual, combined with my research on healthcare accessibility. Through both personal observation and academic inquiry, I've come to deeply understand the barriers that exist and the opportunities we have to create more inclusive, equitable healthcare systems. I hope that my presentation has offered you something to reflect on, perhaps a new perspective, a question to explore, or even a small change you might bring to your own practice. Thank you so much for your time and attention on my presentation. And I am very looking forward to your feedback. And I'm also still waiting for any other collaborative research for the medicine or rehabilitation experts in clinical settings. So it'll be greatly appreciated if you could reach out to me by using this email contact. Thank you.
Thank you, Dr. Cho. You shared such a wonderful news. Congratulations, sending lots of good wishes to you and your growing family. Also, beside what my research focus is, I've been working with a mentor who is visually impaired and a father who also has a visual impairment. So your talk really hit home for me, and I know it resonated deeply with many of our audience who had similar experiences. And I also want to echo that so many people mentioned and that your life experience, your lived experience brings such an important and powerful insight to this topic. So a couple of questions that the first one that also was mentioned from one of our audience. You highlighted the role of family members as access mediators for blind patients. In your view, what would be the first priority change healthcare institutions should implement to reduce this unfair burden on families?
That's a really insightful question about improving the informal caregiver support for patients with disabilities. First of all, providing some available resources in hospital settings will be very helpful for family caregivers. For example, any available transportation services or providing alternative formats for patient information for their self-care engagement, or any additional sessions for sharing the concerns of family caregivers and to share their caregiving burdens for improving the support for patients with disabilities. So this kind of small services will be very helpful for reducing family caregiving burden and to support independent self-care engagement of patients with disabilities. One of my idea would be to have a consultation session with a main family caregiver as well as patients with disabilities. We could have a discussion over what kind of information access methods will be usable for them and what kind of needs or so supportive needs will be helpful for reducing their additional burden for using healthcare services. So those kind of smart conversation offer will be very appreciated from the perspectives of family caregivers and patients with disabilities.
Thank you. Sorry. Thank you so much. So one more question that I have, after your like the curriculum that you mentioned, have you observed any noticeable change in attitude or competencies of the student after the completing the accessibility modules, or you haven't noticed anything?
Yeah, I thank you for the question first. I taught 13 undergraduate and graduations in applied health sciences to introduce the concept of accessibility and universal design principles in the context of healthcare. They've never heard about accessibility before. Accessibility concepts has been developed from the STEM field to design inclusive technological solutions for users with disabilities. That's the originality of accessibility. So many students have questions about the definition of accessibility. Only thought about the physical accessibility, whether the stairs or elevators are usable for people with disability. That's all. They've never thought about the application of this concept to healthcare services. So when they gain the insights about the definition and significance of accessibility in the context of healthcare services, they initiated to think about whether the proposed medical services are accessible for patients with disabilities. They never thought about the invisible disability. They only think about the wheelchair users or amputee, but that's all. So that curriculum widened their eyes about the diverse types of disabilities and multimodal approaches for satisfying their needs of inaccessible healthcare systems. And as healthcare experts, what they can do to improve their healthcare service utilization. So it really was a opportunity for eye-opening opportunity for future healthcare leaders. They were able to learn about the diverse cases, which includes significant needs of patients with varying degrees of disabilities, including their family caregivers. They really are satisfied with the provided content, and they really want to learn more about they can design the accessible or inclusive healthcare services for patients with disabilities.
Wow, that's so promising. Thank you so much. Hope for the proactive healthcare rather than reactive. So thank you so much.
Thank you.
Thanks.
Thank you so much, So Young and Maya. That was an amazing presentation. I was really blown away by the use of technology that you described. Has such a promise for improving care for people with blindness. And I just think it's so admirable and frankly cool that you incorporate your lived experience into your research and how everything seems to be like synergized in your life towards one focus. I think it's wonderful. Thank you for that presentation.